So let's cover the small bone, which is one of the support bone for the tibia lower part of the body, which is placed on the lateral side of the foot, lateral side of the leg actually. We call them as fibula. This is not a weight bearing bone. This is a long bone. As you can see, this particular bone has got features which can be divided into upper end and lower end and the shaft in between, just like any long bone has. So upper end, which has in a circular part, we call them as head, and head has a feature which is projected to the pointy part, we call them as apex of the head, which is also known as styloid process. Then after that, with this particular circular part, which has a facet for the articulation with this tibia counterpart, which is having on this particular head region. After this circular head, we have this narrow part, we call them as neck of this particular fibula. Then it begins with this particular region as the shafts of the fibula. Then we have the lower end. The lower end also have the articular feature, that means it articulates with the lower end of the tibia with the corresponding side, and has a ligament attachment side, we call them as malleolar fossa. So this has got like a same three features: upper end, shaft and lower end. Any long bone whenever given, be it like upper end, be it upper extremity, be it lower extremity, have got these same three features that need to be covered: upper end, shaft, lower end. And then upper end have got like head, and this head as a projected part, we call them a styloid process. And then we have this, after the head we have the narrow neck, which is the prominent into this particular fibula bone. So this consists of the upper end. Then we have the lower end, have got articular facet, and this particular point we call them as malleolar fossa, which is present as a groove. And this particular lateral side of this particular bone, we call them as lateral malleolus, which is the other side of this particular uh, tibia, that is known as medial malleolus. The opposite side will be lateral malleolus. So lateral malleolus is also subcutaneous, just like medial malleolus. So which is point of concern for us for identification. Now then onto this particular head, have got circular part, then we have the narrow neck. This particular region we call them a shaft. Shaft have got like likewise this tibia also have three borders and the three surfaces. So three border and three surfaces. One of the border we call them as anterior border, then we have the interosseous border, and then we have the posterior border. So three borders are there, which is anterior border, posterior border and this interosseous border. We have to identify this anterior border, posterior border, interosseous border, and it has got surfaces like it has got like the surface which is known as interosseous surface, which is on the medial side, as well as it has anterior surface and posterior surface. So this has got three surfaces. Likewise this particular border, medial border, posterior border and lateral border. This particular posterior border need to be identified because of number of like muscles attached to it. Medial border also known as the interosseous border. Lateral border also known as peroneal or fibular border, where you have the muscles attached to it, which is known as peroneus longus, peroneus brevis likewise. And the lateral malleolus, which you have to identify. Now whenever you are given this particular bone, you have to identify is anatomically. So you have to identify upper end and lower end, then you have to identify the anterior side and the posterior side, then you have to identify this medial side and the lateral side. So first thing, we have to identify the upper end, which is presence of the circular head with this particular styloid process, also known as apex, which is present above. So styloid process and this particular apex present on the head, which is upper side. This is the upper end, and the lower side is a medial is the malleolus, which is the lateral malleolus. Then we have to identify the medial side and the lateral side. The medial side and lateral side is identified by this particular malleolus. Malleolus present on the lateral side, which is a prominent feature, which is subcutaneous. We can feel this particular lateral malleolus, which is bulged out in the lateral part of this particular ankle joint as well. Then we have to identify this particular side, which is known as this anterior and posterior. This particular area, which is known as the styloid process, also known as apex, is directed posteromedially. Posterolaterally. I'm sorry. This apex is directed posterolaterally. So this has to be placed on the posterior side. So this is present on the posterior side, and so is this particular malleolar fossa. For this particular holding of this particular lower part of this particular malleolus, we have the facet. This facet we call them as articular facet for the tibia, and under to it we find a groove for the attachments of some ligaments. We call them as the malleolar fossa. This malleolar fossa is present on the posterior side. That means it has to be placed on the posterior side. So this is how we are going to identify it: above, below, medial and lateral based on this lateral malleolus, and this particular anterior and posterior, that is the most prominent thing or most important thing to identify this particular bone and holding it in anatomical position is that you have to identify this posterior thing about this particular apex is directed posterolaterally and this malleolar fossa is placed on the posterior side. So, this particular side determination is a kind of tricky thing that you have to master it and you have to go through this. So, once this particular bone is given to you, you have to identify this particular upper end and the lower end first. Once you identify the upper end and lower end, then it becomes like easy for us to identify rest of the things. Upper end, this is a circular head, this is flattened little bit triangular in shape, this is the lower end which is known as this malleolus. This malleolus we call them as lateral malleolus. This is the upper end which is having a head, and on the head it is projected upwards over here, we call them as apex of the head, also known as styloid process. We have a ligament which is known as fibula collateral ligament ending on it. So, this particular styloid process or this particular apex of the head need to be identified first. This is should be directed posterolaterally, as I am saying posteriorly, backwards and lateral, that means it should be obliquely directed. Posterior and lateral, in between them we draw a line, posterolaterally, obliquely it will be placed whenever we are holding it. But anyways, in the head we have a facet for the articulations of this bone to the tibia as it is joining with this particular tibia. So, this articular surface, this one is on the present on the superomedial surface which is present on this side, right. So, this is a head, and after this head, this part we call them as neck, where I am holding. This neck is very important for this particular bone. Then this one is shaft, then we have the lower end. Once you come to the lower end, this is the lateral side, we call them as lateral malleolus, where I am rubbing my fingers here, this is the lateral side. This is lateral malleolus. Inner side will be a medial side. Medial side, there are two features. Anteriorly, we have a facet. So, anteriorly we have the facet, this facet we call them as the articular facet. This one articulates with the lower end of the tibia. So, this anterior facet is there, and posterior to it we have a depression, we call them as malleolar fossa. So, in the lower end we have to identify this. This smoothness is there which has to be placed anteriorly. So, this should be placed anteriorly, and this posterior to it, that is posteriorly directed things will be there which is known as malleolar fossa. This malleolar fossa where we will be holding this particular bone like this in anatomical position whenever you is holding this, right. Now, this is about lower end, this is about upper end. Then we have the shaft in between. We have 3 borders and 3 surfaces on it. The shaft have got borders, we call them as anterior borders. Say anterior border, if it is posterolateral, this one is a border which is going down and ending towards lateral malleolus laterally. This is the anterior border. So, this border, we have a chalk. Can you grab a chalk please? Oh, I have a chalk, no worries. So, this border is anterior border which I am marking with this blue or green. I am a little color blind, do not worry about it. So, this one, the green line which is ending towards this lateral malleolus, starting from the anteriorly and curving back posteriorly, ending on the lateral malleolus, this one we call them as anterior border. So, if it is anterior border, medial to that we have another sharp border. This border we call them as interosseous border. So, these two lines, if you identify anterior border and this interosseous border which is present on the medial side, then we have this particular posterior border which is present on the back side. So, another border which is present on here, which is present on the back side, which is called as posterior border. So, anterior border, posterior border and interosseous border, these 3 borders you have to identify. So, here as well you have to identify this particular end, as you can identify this one should be this particular anterior border or something like that. This one is saying anterior border, so should be starting from here and it should be going backwards, it will be moving backwards, as you can see, cannot see it from anterior side. So, anterior border, and medial to this particular anterior border you will find this particular interosseous border which is present as like a halfway, it is ending here. So it is present on this particular middle portions of the shaft. This particular interosseous border is there, and opposite to that we have this posterior border which is present on it. So anterior border, posterior border, interosseous border, you have to identify. Once you identify this particular anterior border, posterior border, interosseous border, then going for the surfaces. Between this particular posterior border and the interosseous border, we have the surface, we call them as posterior surface, which is present on this side. Now between this particular anterior border and interosseous border, we have a medial surface which is present, and between this particular anterior border and the posterior border, we have the lateral surface. So we have three borders, three surfaces into this particular region. So we have to identify the borders and surface will be come on. Anterior border is coming on here, the green line starting from anterior aspects of the head and ending towards this particular back side, curving back, ending on the lateral malleolus. Medial to that we have the interosseous border which is sharp, where the interosseous membrane is attached to the opposite side of the tibia, and posterior border which is present on this particular posterior side of it, and likewise we have this posterior surface, lateral surface, and interosseous border which has anterior surface. So these three have to be identified properly. So once again, you have this particular bone. Once you have this, identify this particular thing, this is the styloid process, easy to identify, which is more prominent than that of rest of this. This is also, whenever you get this particular thing, upper end and lower end need to be identified based on this particular styloid process. You see the styloid process that has to be placed on this particular region posterolaterally. It has to be directed. So directions of this apex will be posteriorly and laterally, it will be likewise. Now the important thing about this particular bone have got lower end about having this particular groove, we call them as malleolar fossa. This particular malleolar fossa is directed posteriorly. So whenever you are holding this, say for example I am holding this particular bone like this. So how this particular malleolar fossa is directed? It is anteriorly or posteriorly placed? No, this is the groove. So you can see it from the anterior side. So if you are seeing it from anterior side, this will be anteriorly placed. তোমরা যদি সামনে থেকে দেখতে পাও তাহলে কি আমি anteriorly ধরেছি? It has to be placed posteriorly, so it will be placed facing towards you. So you will be facing this particular malleolar fossa towards you. That means you are standing posteriorly and this particular person is lying there. So this is assuming your fibula you are holding. So this malleolar fossa need to be placed posteriorly, and this facet should be facing anteriorly. So this facet should be facing your examiner, and this malleolar fossa you will be grabbing on and should be heading towards this particular your side. Then you have to place it this upper end, and this has to be placed in the posterior lateral directions. So if it is posterior like this, lateral like this, and you have to grab it in between, posterior lateral. So this is the way you will be holding that, and it belongs to the left side fibula. So left side fibula you will be holding it. Once you identify this, then you have the anterior border, interosseous border, and posterior border likewise, and the surfaces between them you will be identifying it, right? Medial surface, lateral surface, right? Now before you move any further, make sure you identify this particular side determinations of this particular, to this side, to this side. So malleolar fossa is the thing which you will be holding it, right? Identify the facet on the articular facet on this lower end malleolus. Lateral and medial easy to identify, so likewise we have to grab it. Facet will be facing forwards, facet should be facing forwards, fossa will be backwards or posteriorly directed. It has to be held in a posterior direction. The facet will be facing the examiner. The facet will be facing examiner. Anterior facet, the facet will be facing anterior, and fossa is posterior. Fossa will be behind. Fossa ta dekho, fossa ta exposed hoye thakche naki. How the fossa is there, that's the thing that you will be heading. Lateral and medial is easy to identify. Lateral malleolus will be placed on the lateral side. Medial side and lateral side easy to identify. Medial side has got two features. Anteriorly we have the facet, and posteriorly we have this malleolar fossa. Malleolar fossa gives an attachment to a ligament. আগে তুমি অ্যানাটমিক্যাল পজিশনে ধরো, বর্ডার তিনটে বর্ডার, অ্যান্টেরিয়র বর্ডার, ইন্টারোসিয়াস বর্ডার, পোস্টেরিয়র বর্ডার। এবার অ্যান্টেরিয়র বর্ডার আইডেন্টিফাই করো। অ্যান্টেরিয়র বর্ডার, হ্যাঁ, ইন্টারোসিয়াস বর্ডার মিডিয়াল টু ইট, পোস্টেরিয়র বর্ডার, গুড। এবার সারফেস আইডেন্টিফাই করো। অ্যানাটমিক্যাল পজিশনে ধরে দেখাও আমাকে, অ্যানাটমিক্যাল পজিশনে দাঁড়িয়ে অ্যানাটমিক্যাল পজিশনে ধরে দেখা। ফ্যাসেট কোথায়? Styloid process কোন দিকে directed? ধর posterior lateral কোন দিকে posterior কোন দিকে lateral একটা হাতুড়ি নিয়ে আয় তো হ্যাঁ তারপরে ম্যালিয়ার ফসা কোনটা কোথায় দেখা আমাকে দেখতেই পাচ্ছি না তো হ্যাঁ ওটা ম্যালিয়ার ফসা কোন দিকে থাকবে ম্যালিয়ার ফসাটা পোস্টিয়ালি আছে বেশ তাহলে ধর পোস্টিয়ালি দেখে এরকম এরকম করলে হবে নাকি কোন দিকের এটা কোন দিক কোন সাইডের আরে পাগল এটা কোন দিকের ফিবুলা হ্যাঁ কি করে ডান দিকের হলো দেখা তোর অ্যানাটমিক্যাল পজিশন কোনটা ল্যাটারাল সাইড ফ্যাসেটটা কোথায় আর্টিকুলার ফ্যাসেট ওই যে তলার so once you have figured out this particular border surface and different parts you have to know about muscle attachments to it so there are few muscles attached to it so on the posterior side there are few muscles like if you're going for these surfaces individually identifying it, it will be difficult to memorize. So rather than just memorizing this particular border and surface and individual muscle attachment of knowledge of individual muscle attachments to it, it is easy to identify. So you looking at the posterior part or posterior surface right from this particular head up to this neck and shaft region. On this upper region on the posterior side we have soleus muscle attached. So upper side we have the soleus muscle which is related to this particular soleal line on this tibia. So this soleus muscle is present on the upper side posteriorly and under to it tibialis posterior muscle attached to it. So this tibialis posterior which is lying on this particular inner side also known as the medial surface and soleus is present on this particular posterior surface or posterolateral part of whole of this particular region. So on the back side this particular bone or posterior surface of this particular bone starting from this head, neck and this particular posterior surface, soleus and this particular tibialis posterior is attached to it. Lower part of the shaft is occupied by this particular muscle, we call them as flexure hallucis longus. So these three muscles are kind of important for us, soleus and posterior tibialis and under to it is known as flexure hallucis longus. These three muscles that is related to it. If you relate this particular muscle attachment to this particular tibia and as well as the fibula, then it is easier for us to memorize. So we have learned this particular soleal line present on the posterior side of this tibia. The soleus muscle has got like a thin linear attachment here. Rest of the soleus has a fleshy or bulky attachments on the head, neck and half of the shaft here on the fibular posterior surface. And on the medial side or also known as this particular interosseous side, we have this particular tibialis posterior attached to, where this tibialis posterior, you can see that this is attached on the tibial side as well. So this particular tibialis posterior and soleus, they are attached on the posterior side. Under to it we have a muscle, we will call them as flexure hallucis longus. This is the back side, the muscles on the back side we call them as flexure muscles. So flexure hallucis longus, this is attached on the back side. Coming to this particular anterior side, we have few muscles that you have to memorize, especially on the lateral border or lateral margin. So in lateral margin we have a muscle, we call them as fibularis longus above and fibularis brevis below. So this particular border which is starting from the styloid process, if you trace down that particular border starting from the styloid process which is the correspond to the lateral border, on into which we have two muscles attached, we call them as fibularis longus and fibularis brevis. So you remember these two muscles at least about the fibula because this particular muscle named according to the fibula. So starting from this particular styloid process which is directed posterolateral, just track down the line which is lying below and that particular surface is attached with these two muscles, fibularis longus above and fibularis brevis which is lying below. Now if you go by this interosseous border which has got like two muscles attached to it, we call them as extensor muscles, extensor digitorium and extensor hallucis. So extensor digitorium longus, extensor hallucis, we have seen this particular extensor muscles coming in the front of the foot region as well. Whenever you are going to doing the dissections in the previous week, we did these dissections of the extensor hallucis, extensor digitorium muscles, that muscles on the medial side or interosseous borders close to that on this surface it has an attachment to it. So these two muscles need some kind of like a memorizing or required to, you have to memorize this particular muscle which is known as fibularis longus above and fibularis longus below and on the medial border we have this particular extensor muscles, extensor digitorum and extensor hallucis. This is extending to the anterior surface as well. So, going from the interosseous border which is arching in between this particular anterior border and interosseous border, we have the anterior surface where these particular two muscles are attached to it. But anyways, if you just cannot remember at those details, just let go. Remember this particular fibularis longus and the fibularis brevis. There are two of these attached on this particular under to this particular styloid process. Track this particular entire region, that is marking with this particular fibularis longus and brevis. Moving on the back side, which is known as the posterior side, you remember this soleus muscle which has the other attachment on the soleus, and tibialis posterior which is on the medial side or interosseous side on the back side. So, tibialis posterior and soleus and this fibularis longus and brevis, these four muscles, at least you remember them. Now, other than this, we have to remember one ligament, we call them as lateral collateral ligament, also known as fibular collateral ligament, which is anchoring to this particular styloid process. We have seen this styloid process, also known as apex. Into this apex, there is a ligament attached. We call them as lateral collateral ligament, also known as fibular collateral ligament. So, this fibular collateral ligament is an important ligament that you have to you have to remember that particular ligament as well into this particular region. So, this one ligament at least and these four muscles, soleus and the tibialis posterior and the fibularis longus and brevis, attachment to these particular muscles, this is kind of like the thing that you remember or must remember. Other than this, flexor and extensor hallucis longus and brevis from the anterior side and the posterior side, they have attachment on these particular muscles as well. So, if you cannot remember this particular extensor hallucis, extensor digitorum or flexor hallucis, flexor digitorum, just like don't just like remember, but you cannot forget about this fibularis longus and fibularis brevis, neither you can forget about the soleus and this particular tibialis posterior. So, these four muscle attached to this particular bone, apart from the side determination of this bone, which is most important about this particular bone, about determining the side, which is tricky one, which you have to pay attention whenever you are holding this particular bone. Once you identify this particular bone, rest of this particular exams are going to be easy, because this particular bone have got the most tricky thing is about identifying the sides properly. The thing is that you have to identify the above and below first, then the shaft. Above and below, once we identified above, we have the head with the styloid process. Directions of the styloid process you have to keep in mind. It is directed posteriorly and laterally. So, it is posteriorly laterally directed and it has a ligament attaching with it. We call them as fibular collateral ligament. Now, then we have this particular lower end which has got malleolus, which is present on the lateral surface. So, malleolus, which is the smooth part, which is you can feel subcutaneous part, outer side, which is present on the lateral side, which is known as lateral malleolus, which is smooth. This medial side, which is having got two features, which is present on the medial side of it. One is anteriorly placed with the facet or articular facet. This articular facet articulates with the tibia, which is making a kind of like a fibular facet. Under to it, we have a groove, which is having this particular groove, we call them as this groove as malleolar fossa. This malleolar fossa, which has to be placed posteriorly. That means you will be pinching your fingers to hold this particular region to this particular malleolar fossa, and this particular articular facet should be facing anteriorly. So, that articular facet should be facing anteriorly, and this particular malleolar fossa should be placed on the posterior side. So, anatomically, whenever you are holding it, holding this particular part is important, keeping this particular apex directed posterolaterally. So, just like hold this particular medial this malleolar fossa first, keeping these things posteriorly, then you switch this particular apex posterolaterally. So, that will be easier thing. So, whenever you are given this particular bone, hold this particular malleolar fossa with your fingers, then you direct this particular styloid process accordingly. The directions of the styloid process will be placed on posterolaterally. So, likewise you have to just like a twist it posterolaterally, which will be easy, and whenever you are twisting it or untwisting it, make sure this facet should be facing anteriorly and malleolar fossa will be on the back side or posteriorly placed. So, it's be it right side, be it left side, depending on how this particular bone is you are holding is important for us to be identified. So, This malleolar fossa, you will be grabbing it like this. Once you grab this malleolar fossa, then make sure that this particular styloid process should be directed posterior laterally. That things helps us to identify. Then you identify the anterior border, which is going towards this lateral triangular part of this particular lateral malleolus. Medial to that, we have another sharp border, interosseous border, and then we are left with one border, which will be the posterior border, which will be placed on the back side. Posterior surface, medial surface, and the lateral surface, we will be identifying it properly. So, this is the thing we will be identifying. Make sure we have right side fibula and the left side fibula. Make sure you identify both of them, and once you identify the both of them, just like identify the styloid process, ligament attached to it, then we have to identify this particular region as the under to it. We have this fibularis longus, under to it fibularis brevis. Flip it on the posterior side, soleus, which is present on the medial side or posterior medial lateral side, and this tibialis posterior, which will be attached on the medial side. So, this is about this particular bone. Side determinations of this particular bone is again which you need to be focused. So, we are going to cover the next small bone, which is related to this particular lower extremity. We call them as patella. So, this diagram, as you seeing here, is involving the knee joint, showing this particular bone image. We call them as patella, which is present in front of the knee joint. Now, this is a bone, kind of bone, we call them as sesamoid bone. This particular bone develops from the ligament or tendons of it. So, this particular bone which develops from this particular ligaments and tendons of it, we call them as sesamoid bone. Now, we have a tendon which is related to this particular front of the knee joint, we call them as quadriceps tendon. So, this quadriceps tendon which is present in it formed by three different muscles. We have the vasti 3 muscles, vastus medialis, vastus lateralis, vastus intermedius. 3 of these particular vastus muscles are there. Along with that, we have this rectus femoris, which is a front muscle. Meeting together these 3 and this rectus, making a tendon, we call them as quadriceps tendon. This quadriceps tendon within it, which is present in the front of the knee joint and the thigh as well, runs in here, and as a result of that, this particular friction and yields a kind of bone, we call them as patella, which develops after birth. So, this particular bone which you are seeing here, we call them as patella, which looks like this. So, this particular patella have got like a few parts. It has an external surface, it has an internal surface, it has a pointy part, we call them as apex, and it has a broad part, we call them as base. So, this external surface and the internal surface need to be identified. Easy to identify. External surface is rough and the inner surface is smooth. The inner surface is divided into a vertical groove into medial and lateral part. Lateral groove is a larger one and medial one is a lesser one. So, we have 2 grooves present on this particular side, which is splitting this particular bone into this medial side of inner side into 2 parts, larger lateral and smaller medial groove. So, we have to just like see this particular groove to identify this particular bone. So, first thing first is that you have to identify this base, which is present on the upper side, apex, which is a pointy lower side, which is directed towards the foot, the apex, and this one is directed upwards. So, this is apex, broad base and pointy apex. So, this is present on the downside, this is present on the upper side. Then you have to identify the external and internal side. The external side is rough, internal side is smooth. Once you see this internal side having this particular smooth surface is divided into 2 parts. This part we call them as articular facet. This articular facet is divided into 2 parts, medial and lateral. If you look at this particular surface on the medial inner side, this particular vertical groove which is splitting this particular region is divided into 2 parts, medial half and lateral half. Lateral particular groove is larger. So, whenever you are determining the side, you have to identify this lateral side. Easy to identify this. Place this particular bone on table, it will be falling on the lateral side. So, this is on the lateral side, it will be falling. So, it will be on lateral side, this is the medial side. This is how we are going to identify the lateral side of it, medial side of it. This is as well. You place it on table vertically, this particular thing which is having the larger lateral one, it will be tilting to that side. Easy to identify. Then you place it anteriorly, posteriorly, based on this anterior surface, posterior surface, apex is directed down and base is above. So, this side, lateral side, which will be placing laterally, it will be this side bone, right side, and this one is resting on the left side, left lateral side, this will be on the left side. The easy side determination is there for this bone. Now talking about the muscle attachment, all these particular muscles, as I mentioned, quadriceps muscles are attached to it. Middle portions, we have a muscle, we call them as vastus medialis or intermedialis. Medial side we have the vastus medialis, lateral side we have the vastus lateralis, and this particular quad rectus femoris, which will be superimposing on this particular intermediate part, central part, which will be coming on. So after this tendons, once you have this particular blending on this particular region, which is making this particular quadriceps tendon, after that we have an extension of this particular quadriceps tendon, which is coming from the apex of this bone and ending on the tibia or tibial tuberosity. We call them as the ligamentum patelli or patellar ligament. So after this particular bone, which is ending on this particular region, this particular tuberosity on the tibia, we call them as tibial tuberosity, which is present on the front side. Here we have this particular extensions of this quadriceps ending as a ligamentum patelli, which is ending onto this particular bone. So this particular bone have got like a easy thing to identify. We have these muscles, which is all the quadriceps muscles anchoring into it. All the three vasti, medialis, lateralis, intermedius, and the rectus femoris have got like a tendons, which is spanning out. We call them as retinacula. We call them as a retinacula or patellar or tibial or knee joint retinacula, which is ending on it. And after that, we have this continuations of the quadriceps tendon, which is known as this particular ligamentum patelli. So this particular region you have to keep in mind regard to this particular clinical anatomy of this bone regarding to the problems which is elicited out here. So we have this particular lateral view, we have to identify this particular basic attachments of these ligaments related to this particular bone. So if you are seeing here, we have the three muscles merging in here, vastus lateralis, vastus medialis, and this particular vastus intermedius. They are bending, superimposed by this particular rectus abdominis. They are making this particular tendon. We call them as QT, as quadriceps tendon. So this quadriceps tendon ends on this particular bone. We call them as patella, which is ending on here on the fibers ending and making a kind of extensions like this. We call them as retinacula of knee joint, retinacula of the knee joint. And then we have this particular ligamentum patelli extending from it and ending on this particular tuberosity. We call them as tibial tuberosity. So up to this particular inferior angle or this particular apex of this particular patella to this particular tibial tuberosity, we call this as ligamentum patelli. So this ligamentum patelli is an important thing. If you just like strike it with a hammer in this region, that elicits knee jerk, which is a knee jerk reflex pathways is created. I am not going to into this particular part, but this particular ligamentum patelli, identifying this tibial tuberosity is important for us to identify. Second thing about this particular thing, what you have learned so far, we have this particular bone, we call them as this fibula, and this fibula have a narrow part, we call them as neck of this particular fibula. So this particular neck of the fibula, which you have seen, which is lying below the head, has an important nerve going by. We have a nerve which is passing here, we call them as common peroneal, also known as fibular nerve, which splits into two branches, which is known as superficial fibular and deep fibular or deep peroneal. So this particular common peroneal nerve having a close relationship with the neck of fibula. So by accident, if you have a fracture of the neck of the fibula, we may have a damage to this particular fibular nerve. Just like we have talked about this particular fracture of the neck of the humerus, we have this axillary nerve there. Here we have this nerve which is present in here, we call them as common peroneal nerve. The common peroneal nerve have the two divisions, superficial peroneal and the deep peroneal. Superficial divisions and the deep divisions both are mixed kind of nerve. That means it supplies this particular muscle, it supplies this particular skin as well. So this particular muscles which is supplied by this particular, which is present in the foot region or this leg region, which is supplied by the common peroneal nerve, is a muscle which is doing an action which is known as dorsiflexion. So by any chance, if you have a damage to this particular peroneal nerve, we have a loss of dorsiflexion and leading to foot drop. So if you have this particular problem, we have this particular patients coming here like foot drop. And if you ask this particular patient to just like lift it, they cannot do it because the muscles which are lifting this particular foot is not there. We call them as dorsiflexion. So there are two kinds of movement present in the foot. We call them as plantar flexion and the dorsiflexion. Dorsiflexion is this extension kind of thing that we are seeing here. We call them as extension in this upper extremity, but in case of the foot region, we call them as plantar flexion, which is actual flexion, and the dorsiflexion, which is nothing but the extension. So if you're lifting this foot up, if you're lifting this thing up, which is extension kind of thing, but in here we call them as dorsiflexion. This part of the foot we call them as dorsiflexion movement. And if you just like doing this thing, which is kind of flexion, we call them as plantar flexion. We do not use this word as the flexion and extension in case of this way we have used that in upper extremity. So this particular muscles which are supplying this particular lower extremity, which is going to supply these extension muscles, loss of extension muscle movement leads to this foot drop. So if you have a damage to this particular common peroneal nerve, which is because of the fracture on the neck of the femur, we have a foot drop, and this particular foot drop is a common thing which is having this particular injury on the sides of the foot region. So you have this particular articulated, we have this articulated foot there. So you can see this particular bone is skinny one present on the lateral side of the leg. So if you have an injury from coming from the sides, we have a injury prone region of this region which is leading to this fracture of here. So we have a nerve which is passing through here around the neck region. On top of this fibularis longus and fibularis brevis here related to it. So a nerve passing by, it can be trapped if you have a neck fracture here in this region, and this particular nerve we call them as common peroneal, also known as common fibular nerve. So this common peroneal and fibular nerve is a mixed kind of nerve which splits into two branches, deep and superficial. Both of these are supplying the muscles, we call them as this particular extension and this particular peroneus muscles or fibularis muscle. So the prime effect will be there will be a foot drop to the patients. The foot will be dropped like this. So if you ask the patient to lift it, they cannot lift it, which you normally can do. So this absence of this lifting of foot, we call them as dorsiflexion absent, is known as the foot drop thing or ankle drop. So ankle drop is a kind of thing we all also have learned, that like wrist drop, radial nerve palsy, something like that also happen. So this region has got this particular problem which needs to be taken care of. Apart from that, this particular bone have got like a, as I've said, this is not a weight bearing bone. So it has a muscle which is attaching to it. It's attached to this particular tibia side of it, giving some kind of support to this tibia, but it is not bearing any kind of weight. Only it is taking some loads from this tibia so that muscles can be attached on these regions and blood vessels and everything can pass through it. So this particular bone can be used as bone grafts. So if you require to have a bone to be grafted somewhere, you have a destruction of the bones elsewhere, you can take this particular bone for grafting. Piece of bone can be taken out and can be grafted elsewhere. So it can be used as a bone grafting, and as well as it can be used for modifying some kind of other things which is required for constructive or reconstructive surgeries. So surgical bone sacrifice can be done, can be used for this particular bone for grafting elsewhere or doing some reconstructive surgeries. So these are the things about this particular fibula and this particular patella. Patella is a kind of bone, we call them as sesamoid bone, and sesamoid bone is a kind of like a bone where it is developed after birth and it develops within the tendons, and these sesamoid bones do not have medullary cavities which is other bones have got, and it is grown after we are born with the frictions and everything. This is the largest sesamoid bone that we have. There are many of them. This is the largest one, and again side determinations of it, easy to think as is that place it on a table, it will be tilting on the left side, tilting on the lateral side. So it will be tilting to the lateral side because it has a facet which is present on here, articular facet, which is on the larger on the lateral side. And what this particular bone is attached to it, it attaches with this particular bone which is lower end of the femur. So it have the femur which has got like anterior lower surface. Here we have this particular attachments of this particular femur with this particular patella like this, making a joint. We call them as patellofemoral joint, which is a part of a knee joint which can be contained or extended part of knee joint. So, patellofemoral joint or femoropatellar joint is a kind of like a joint which is present on the side. So, besides that, this particular bone, we have one thing to cover about this is articulated foot. So, we will cover that particular articulated foot in radiology classes as well in this part. So, it has got like a bones just like upper extremity has. We have the carpal bones, we call them as tarsal bones. We have this metatarsal bones, we have the metacarpal bones, and phalanges likewise. The name will be different, and one or two bones we need to identify. This big bone, this one is talus and the calcaneum, and a navicular and this particular cuboid bone we have to identify it radiologically and as well as through identifications of the bone as well. This is again very easy class, we will be talking at in next class. So, again this particular bone rehearse properly so that you can hold this particular bone in proper anatomical position. If you hold this particular proper anatomical positions, then this particular bone is easy. Upper end, shaft, lower end. This upper end have got neck, body, styloid process. Lower end have got like part, we call them as medial lateral malleolus. Inner side you have the facet for the articulations and malleolar fossa. Malleolar fossa should be directed posteriorly and styloid process should be heading posterolaterally. And then we have the muscles attached. Lateral border have got two muscles to attach, which is known as fibularis longus and brevis. Posteriorly we have the soleus and the tibialis posterior. These four muscles we are memorizing. Other than this, we have the extensor and the flexor digitorum and which are present on this particular bone as well. If you cannot remember the detail of it, just go and go by. Neck of this particular bone is related to a nerve which is known as common fibular or peroneal nerve. Common fibular peroneal nerve is the extension for coming from this tibial nerve basically. So, anyways, we will learn about that more if we haven't learned that yet. The common peroneal nerve splits into two branches, deep branch and superficial branch. Both of them are mixed branch. That means they supplies the muscle, they supplies the skin. What they do? They supply the muscles which are present on the anterolateral compartment of the leg region. We will be learning that in anterolateral compartment muscles, etc., etc., and as well as the bony attachments as well. But anyway, the thing is that these muscles are doing an actions on this particular foot region or ankle joint. We call them as dorsiflexion. That means they are lifting the dorsum. So, dorsum part will be flexed, bent. So, we will have this particular common peroneal nerve damage, we have a loss of dorsiflexion. That means patient cannot lift this particular foot, leading to foot drop. So, patient will be coming with the foot drop if they have a fracture on shaft or upper end of the shaft or neck fracture of fibula.